Inductions are one of those interventions that most commonly leads to the domino effect. This is where one medical intervention in labor leads to another, and to another, and to another, and to another. This is also called the cascade of interventions. And while inductions and other interventions can help to prevent complications and prevent some serious problems, the issue today is in the United States. Inductions and other interventions are being used so routinely that they are actually causing tremendous numbers of complications because they're being used often in healthy women with completely normal pregnancies. The domino effect is going to usually cause the most dramatic effects in first-time pregnancies, especially if the woman's body is not ripe, if her cervix is not soft and it's not thinned out already and maybe open a bit. Those are going to cause usually the longest ordeals. Sometimes women who've had children before, they can be super easy to induce. Maybe all you need to do is break her bag of water. She'll go into labor and have her baby. But I've seen plenty of women being induced who have had precipitous labors, meaning the baby came super fast. So they were inducing her because they wanted to make sure she'd be in the hospital for the second birth. And those women have been hard to induce, and it does lead to the domino effect also. In a medically necessary induction, of course, you run the risk of the domino effect and the cascade of interventions. But in these situations, it might be well worth it. If you have a woman carrying a baby that is not growing well, and the baby is starting to show significant signs of compromise, of course, inducing the baby could prevent that baby from being stillborn. Or say a woman has preeclampsia, inducing her can prevent her from going into eclampsia, which is these terrifying seizures, which you do not want to see in a pregnant woman. And so that would also be well worth it. The problem here is, again, that we're using these interventions and inductions commonly in women with no medical cause. This is a completely typical normal scenario that occurs that gets the domino effect from an unnecessary induction rolling. This occurs throughout the United States multiple times a day, and unfortunately, I have seen this many times during my career. A woman named Jessica is 38 weeks and 5 days pregnant. She's completely healthy and has a totally normal pregnancy. There have been no complications. She goes to the OB office, and she happens to be scheduled that day with her favorite OB of all the ones she has met during the different visits. This OB offers to induce her in 2 days. He says, "I'll be on call 24 hours that day, and then I'm going away on a 2-week vacation." She really wants him at her birth, so she agrees to this plan. Jessica's OB checks her cervix and tells her that her cervix is not ripe. She'll need to come in on Tuesday evening for a ripening procedure. Jessica doesn't know that most healthy women with healthy pregnancies, they often go a week overdue. So she's really quite early. Her body really isn't prepared for the orchestra that occurs for an easy labor. She also overestimates what modern medicine can do because she watches TV shows and news programs that talk about all the miracles of modern medicine. She's feeling tired of being pregnant, she's not comfortable, and she really likes the idea of being able to plan her birth. She imagines the baby will be here later on Wednesday. We can only hope that the staff advises this woman to eat a good meal before she is admitted. Jessica is super excited. She calls her partner and her family. Her partner, of course, plans to go in with her Tuesday night for the ripening procedure, which can take a long time. Her family plans to arrive at the hospital on Wednesday for the big event. When Jessica gets to the hospital, she realizes she doesn't know any of these staff members. She hadn't really thought about that before. She had gotten used to the staff at the OB's office and bonded with them somewhat. They start to ask her tons of questions, and she says, "Don't you have my prenatal chart? I answered all these questions at the OB's office." They said, "Well, we ask them all again, and we add more." Once Jessica has answered all of the questions, the admitting nurse says that she'll be assigning Jessica to a new nurse who should be with her until 7 a.m. in the morning. She leaves, and the new nurse comes in and introduces herself. She asks her and her husband a few more questions, and then she attaches Jessica to the fetal monitor with two belts that Jessica realizes isn't really that comfortable, but she's pretty fascinated with the graph readouts, and so is her husband. Then Jessica says, "When is the OB coming?" The new nurse says, "Oh, he won't come unless we call him, but he has left orders for what he would like us to do." At 9:30, the nurse inserts a medication deep into Jessica's vagina. Shortly after Jessica receives the medication, she starts to feel uterine cramping. She understands that it's the cramps that are softening and thinning her cervix. She's also hoping it'll open a bit. The OB said the idea was she could sleep while the medication worked, but Jessica realizes about 11 p.m. when she's used to falling asleep that that's not going to happen. The cramps are too strong. Plus, she has an IV, and when she moves her arm too much, the pump alarms. When she turns over, the electronic fetal monitor also alarms. The nurses are coming in and out, of course, because they have to check on her. Her husband is snoring across the room. Jessica, about 3:30 in the morning, the nurses come in and give her another dose of the medication. By 7 a.m., Jessica is pretty tired, though she's still excited. At 7 in the morning, her OB comes in the room with another nurse. This nurse introduces herself to Jessica and her husband and says that she is the new primary that'll be on for the next 12 hours. She writes the name of the relief nurse and some other team members on a whiteboard and her cell number, saying that's the quickest way to reach her, but also gives her the call light. The OB asks Jessica, "How is your night?" And she says she's tired, but she's excited to see how much her cervix has opened. She also says she's been more comfortable the past couple hours because she wasn't on the continuous monitor. The nurses have just been checking intermittently. The OB says, "Well, we're going to have to keep you on the monitor almost all the time once the Pitocin, the synthetic oxytocin, is hung." Jessica understands the Pitocin is what is going to cause the stronger and the more regular contractions. She doesn't understand that it's different than natural oxytocin, which has more calming effects. And all the women I've known who've had natural births and induced labors have told me that the induced ones were more painful. She also doesn't know that this drug has to be given extremely carefully because if the contractions become too close and too strong, they can endanger the baby. It has a black box warning on it, this medication, that it shouldn't be used in medically unnecessary labors because we don't know the risks and benefits of it yet from the data. She also doesn't know that it's involved in a lot of the maternity lawsuits. The OB checks Jessica's cervix and gets excited. He says, "Wow, that cervical ripening procedure, that medication really worked. You're so much thinner and you're so much softer now. You're 85-90% effaced." Jessica said, "How dilated am I?" And he says, "Well, we don't expect the ripening procedure to open you that much. That's more for the Pitocin. But your fingertip," and she says, "How much is that?" And he says, "It's less than 1 centimeter. Jessica notices she feels disappointed. She had hoped that with 2 doses of the medication, she would be further along. She says to the OB, "Did you see my birth plan? I want to remind you that I don't want pain medications in labor." And he said, "Yes, we understand that." By noon, Jessica's contractions are mild and they're far apart. The nurse keeps upping the Pitocin, trying to get her in a good labor pattern. Jessica's hungry and asks for lunch. She's told she can only drink water or juice. Jessica's not aware that this is not supported by the medical evidence and that her body will produce adrenaline, which can slow contractions down. By 5 p.m., she is in a good labor pattern. They're coming every 5 to 6 minutes and they hurt. She asks for pain relief. The nurse gives her a narcotic through the IV, which flattens the baby's heart rate out. This is a normal expected side effect from narcotics, but the nurse is anxious about it and tells the family, which makes the family anxious also. They don't know that this will naturally resolve as the narcotic wears off. About 45 minutes later, after Jessica received fentanyl, that was the short-acting opiate that was given, she notices that the baby's heart rate is starting to return to normal and she's relieved. But the pain is coming back and she tells the nurse. The nurse offers her another dose, but Jessica says, "No, I felt woozy and strange. I want the epidural." The nurse calls the anesthesiologist. At 7 p.m. when the new nurse comes in, she reassures her the anesthesiologist has been called and will come as soon as she's done with the surgery she's involved with. The anesthesiologist arrives about 8:30. She tells Jessica and her husband some of the risks and asks them to sign this consent form for the procedure, saying that they've been informed of all the risks. Jessica signs the consent. She feels confident. She had researched epidurals and heard that they were safe, plus all of her friends had had them. The anesthesiologist did mention that her blood pressure could drop, but that was easily treated. They say to sit up on the edge of the bed. She's having these contractions, remember, and she's told she needs to curl up around her belly and arch her back like an angry cat. That's not that easy to do when you're 9 months pregnant, but the nurse is helping her. The nurse explains they're going to put a very long, thin needle in between two of her vertebrae of her lower spine, and they have to get the medication in a very specific spot. She tells Jessica she needs to be super still, even if she has a contraction, which can be a little bit of a feat. Jessica's feeling really uncomfortable, especially when she gets a contraction, trying to remain still in this position. But she does her best because they said it was so important. She's also uncomfortable because now, in addition to all the other equipment she's attached to, she has a blood pressure cuff that they say needs to remain on her for quite some time. The nurse had also told her that once the epidural took effect, they were going to be inserting a catheter which would remain in her bladder to collect urine in a bag that would remain throughout labor. After the procedure is over, the anesthesiologist and the nurse gently lay Jessica back and tilt her to her side as the anesthesiologist secures this catheter now that's going into her back with the medications securely, and it's attached to another IV pump. I have seen this following crisis I'm going to describe happen innumerable numbers of times during my hospital career. About 10 minutes after Jessica gets the epidural, she starts to relax. She's getting pain relief, and her family is happy that she's more comfortable. They're hoping she'll get some sleep. But then Jessica says suddenly in a very classic woozy voice, "I don't feel well." The nurse looks over and sees that her blood pressure is dropping dramatically. She glances over just as the baby's heart rate starts to plummet. She turns off the Pitocin to help the baby to recover, hits the call bell and nurses rush in. "Turn her on her left side, open the IV lines, put oxygen on her. Is oxygen on 10 liters? Yes, the Pitocin is off. Call the anesthesiologist. Draw me up injections of terbutaline and ephedrine." Jessica, her family, the baby, and the staff are all terrified. Their bodies are pumping out adrenaline. The anesthesiologist comes in the room and says, "Yes, give her the terbutaline and the ephedrine." The terbutaline and ephedrine are both adrenaline-like medications. Terbutaline to slow the contractions down and ephedrine to drive the blood pressure up. With all of this, eventually Jessica's blood pressure comes back to normal and the baby's heart rate is stable. But Jessica doesn't feel good with all this adrenaline running through her system. She's super jittery, like she drank 15 cups of coffee, and she starts to cry. It can take hours to calm everybody in that situation down, enough to be able to restart the Pitocin again. The family expresses deep gratitude to the competent staff for saving their loved ones. In my experience, families don't usually put it together that this terrifying experience was what the anesthesiologist had calmly mentioned when she was getting informed consent, that the blood pressure could drop, but it was easily treated. They often think this was the dreaded OB emergency that came out of the blue and say, thank God we were in a hospital. At 11 p.m., the OB comes in and checks Jessica's cervix. She's 4 centimeters dilated, so he breaks her bag of waters. This will increase her risk of an infection. The nurse calls the OB and wakes him up, saying that Jessica has a fever. The OB knows that he's not going to be able to distinguish whether it's an epidural fever, which has one set of complications, or an infectious fever, which has a different set. Fevers in labor are taken very seriously, and so he orders IV antibiotics to be given just in case it's an infectious fever to protect Jessica and the baby. Jessica isn't moving very well. Between the epidural and all the equipment she's attached to that alarms if she moves too much, Jessica's learned to stay quite still. This is impeding her circulation, and her hardworking uterus and baby need tremendous amounts of oxygen during labor. So they notice that the baby's heart rate is now starting to change, which worries the nurse and, of course, the family. The baby's heart rate has improved because the nurses increased the IV fluids, and they've been turning and moving Jessica more frequently to improve her circulation, and the family's happy about that. At 5 a.m., another nurse comes in, one that Jessica has never met before. She introduces herself and explains that Jessica's primary nurse got pulled away to take care of another patient, and she will be taking care of Jessica for the next couple of hours. Jessica asks when the shift change is, and she says 7 a.m. When does the OB go off a call? And told that's at 7 a.m. also. Jessica says, check my cervix, and the nurse doesn't want to. You have a fever and your waters broke. But Jessica insists. The nurse can see that Jessica's exhausted. She hasn't eaten anything since breakfast of the day before, and she's starting to fray at the edges. She's getting to be the end of her rope. So the nurse checks her and says excitedly, you're making great progress. You're 6 centimeters. Jessica and her family are devastated. They cannot believe that an induction could possibly take this long. Jessica says the only reason I agreed to this induction was because I wanted that OB at my birth. The nurse says she understands that, but that she'll really like the next OB and says her name. Jessica says, I've never even met that OB before, which scares her. And of course, her adrenaline levels increase again, which will slow her labor down. At 9:30 the next morning, the new shift nurse notices things on the monitor that makes her think the baby is starting to descend. She checks Jessica's cervix and finds out she's fully dilated. She's super excited. You can start to push. Jessica tries pushing, but with the epidural, she can't feel anything. The nurse inserts 2 gloved fingers and presses down towards her rectum to try to create some sensation, but that doesn't help Jessica. She's frustrated. She says, I need to get up and squat. The nurse says, you can't. You have an epidural. Your legs are too weak. Your legs won't support you. They try to assist her with different pushing methods, but the exhausted mother and baby are getting stressed, and the baby's heart rate is starting to fluctuate again. The nurse is concerned about the baby's heart rate, so she increases the IV fluids and turns Jessica on her other side, seeing if she can get the baby's heart rate to improve. She calls the OB and says, you need to come in and assess this situation, and gives the OB the technical details he needs to know to understand what is going on. He comes in and does a vaginal exam, and he says, we're going to need to do a cesarean section. The family says, can't you do a vacuum extraction where you put a cup on the baby's head, a vacuum cup, and you help pull the baby out? The OB says, no, that can't be done. The baby's head is too high. It would be too dangerous. They agree to this section. The family's exhausted. Jessica's exhausted. They just want the baby out. So the nurse gives her another shot of terbutaline. So even though Jessica is wiped, now she's feeling all jittery again. The doctor says it's not an emergency, but he does want to get the baby out as soon as possible. The nurses begin all the preparations for the cesarean. They shave her belly and they explain to her what's going to happen, and they complete all of the paperwork. When Jessica is wheeled into the operating room, she's a little freaked out by this sterile environment, but she's so exhausted she just surrenders. She just wants to see her baby. Her husband is also there at her side. When the baby is pulled out, of course the baby's having trouble breathing. It's exhausted and it is stressed. So they wrap the baby up in blankets, warm blankets, and they just whisk the baby by and show Jessica. She gets to touch the blanket. They say, we got to get her to the neonatal intensive care unit. Jessica's super disappointed that she didn't get to see the baby more, but she just wants the baby to be safe. Jessica meets the recovery room nurse, who explains to her that those leads on her chest are for the cardiac monitor and they need to watch her heart rate carefully. She has all this equipment still on her except the electronic fetal monitor, and she's happy about that. She is so exhausted and all she wants to do is sleep, but she realizes she's also totally amped up and keeps asking how the baby is doing. They reassure her that they will get her united with her baby as soon as she and the baby are stable. After an hour, she's moved to a postpartum room and has another nurse who introduces herself. She asks again for her baby and told that the baby isn't stable, but as soon as they can, they'll get her up in a wheelchair and bring her into the nursery. In the postpartum room, Jessica is relieved that they took off the cardiac monitors. She's also surprised that she's not feeling any pain. The nurses explain the epidural pump is still running and giving her the medications through the epidural catheter to relieve her pain. They tell her, though, that the pain will return and then they will be giving her narcotics. She's disappointed because she didn't want to be bonding and breastfeeding while she was on narcotics. But she's happy the baby seems to be doing okay in the NICU and they will bring her there as soon as possible. She and the baby still have a fever, so they're still on antibiotics also. Finally, Jessica is put in a wheelchair and wheeled in and gets to see her daughter and touch her for the first time. Jessica quickly realizes that this ordeal isn't over. She has a cesarean section recovery ahead of her, and the baby's still in the NICU on oxygen and getting different antibiotics as they try to determine if the baby has an infection or not. Jessica still has a fever and is on antibiotics also. Slowly, they wean her from the equipment that she was on all throughout labor. Jessica goes home with the baby at day 5, but the breastfeeding struggles continue. The nurses explain because the mother and baby had been separated for so long. I can assure you, based on my years of hospital experience, that this hypothetical scenario that I made with Jessica is very typical. I've experienced it so many times. This is what can happen when we start unnecessary inductions or give women interventions in labor that were not needed. Remember, the research says that if all is going well, it is best if a woman and a baby go into labor when their bodies decide it is time.